I think Eileen's having a hard time joining. Oh.
Michelle, I'm here.
Oh, okay, because there's two trying to log in right now.
I know, because I couldn't get in my computer, so I went into my laptop.
Oh, okay, gotcha.
Yeah.
Okay. Everybody's in. Good job. Joey got a haircut. Yay. Okay, good job. You're funny. Good morning, pharmacy. It's hump day. Okay, so today I'm going to do a review based on your packet, okay? Because we've been asking you to listen to this audio lectures. I wanted to correct some things in the lecture packet, okay? Because I think I mentioned this in the audio lecture too. Let me pull it up first. Okay, so we've gone over oncology. Okay, oncology is the study of what is the science or the branch of medicine dealing with tumors. When you hear onco, right away, the first thing that comes to mind is cancer. When you hear cancer, the first thing that comes to mind is tumor. Okay, how do you call the specialist that you see when you have cancer or when your primary care doctor thinks that you have cancer? Eileen.
Oncologist?
Correct, oncologist, okay? This is just a review of what you've been listening to, okay? Because I want to check that you're really listening to this audio lectures. Okay, I mentioned things about chemotherapy, right? Chemotherapy is a treatment is a treatment used for cancer. That's what people know, okay? It is toxic, okay? Chemical therapy treatment, chemotherapy, okay? But I keep saying whatever cures cancer causes cancer, okay? It's not only chemotherapy that we use to treat cancer. I wanted to show you. Yeah, it is true. Whatever cures cancer causes cancer. He said it doesn't make sense at all.
Yeah, but then what would be the point of having the cure for cancer?
Okay, let me show you. Share my screen right here. Okay. Chemotherapy is not the only treatment for cancer, just so you know, okay? But that's the most common. Treatments for cancer can be surgery, okay? That means removing a localized tumor, okay? It can be radiation therapy. What is that? You actually make the tumor smaller, okay, until it goes away using radiation, okay? Delivering radiation from a machine to the site of the tumor, okay? What are its uses? When tumor in area is difficult to reach with surgery, okay? When tumor is too large to remove without damaging normal tissues or other organs. When tumor causing pain or impinging on vital organs, which I just mentioned. Residual tumor left behind after surgery. When do we use surgery? When the tumor is localized, okay? When the tumor spreads, when the cancer spreads, what do you call that? I mentioned it, Nyla. When the cancer spreads, what's that term? Letter M. Anyone?
Malignant.
No. Remember
mitosis?
malignant and benign. Okay, but when it spreads, what's the term?
Metastasize.
Was it mitosis? Or
Metastasize.
no?
Eileen said it, I think.
Yes, Eileen said it.
Yeah, metastasize.
It metastasized, okay? Metastasis, okay? So my mom had breast cancer, okay? Towards the end of her life, the cancer spread to the bones, metastasized to the bones. She couldn't even feed herself. She's shaking and she's dropping her utensils. Okay, so that's what the term I was looking for, metastasize. Okay, it's spread already. Okay. Other treatment for cancer, immunotherapy. Okay, the immune system. Therapy, treatment. It's stimulating the immune system to stop or slow the growth of cancer cells. In other words, making your immune system stronger of sorts, okay? Example includes interferons and interleukins, okay? Immune checkpoint inhibitors. So you're gonna hear these terms. I know that your packet has very, very small information, but I want you to know that it's not only chemotherapy that we use for cancer, right, Ms. Risha?
That is right.
And
They're even working on gene therapy for cancer as well.
correct, okay? So gene therapy, when you have history, okay? When you have history for cancer, so most likely the offsprings or the children, because it's in your genes, okay? You have cancer, okay? You may have cancer if you have history of cancer. It's not 100%, but there's that chance. Like my mom died of breast cancer, so we should be cautious about it. We should go for mammogram. Since I hit 40, okay, I should be going for a mammogram every year. My sister, the second one, had breast cancer as well, and she had lumpectomy. She's based in London, so usually in Europe they don't do mastectomy. You know what I'm talking about? Lumpectomy versus mastectomy. Okay, mastectomy, you take out the whole breast. Lumpectomy, lump, you only take out the lump, the tumor. Okay, the difference between the US and the UK or Europe, in Europe, because I have a friend in France who also had breast cancer, and she said the tumor is so big, but they still just did lumpectomy. Okay, mastectomy, taking out the whole breast, lumpectomy, just the tumor or the lump. Here in the US, usually take it out, right? Why? Because it usually comes back. Okay, side effect on women, depression, lack of confidence, and then later on, they're going to ask for what? Surgery for what? Breast
Reconstruction.
reconstruction. Okay. In the past, breast reconstruction is not part of your insurance. However, now more and more insurance includes breast reconstructive surgery if you had cancer and you had mastectomy. That's here in the US. Okay. In Europe, as much as possible, they save the breasts. Okay. They just take out the lump, no matter how big, because my sister's lump is big, my friend's lump is big or was big, and they took it out. Okay. And then they return the nipple and the areola. Okay. Nicely. Okay. Why did they do that? I think the main reason why they did that is because of history. Like women who had mastectomy, 90% of the time they get depressed. Okay. And culture as well. Okay. When breasts play a big function in sex in your culture, you don't want that gone. Okay. And because when a woman loses her breast, confidence level goes down, right? So for the Europeans, they'd rather save the breast, okay? And then less cost on what? Later on, reconstructive surgery, okay? That's the difference. So I was so opposed to it when my sister said, my dad passed away 3 years ago, and we all flew back for the funeral. And she was the last one to come back because she was waiting for the results of her tests. And then finally she got it and she said, yeah, I have breast cancer. And when I go back, I'll have to go through lumpectomy. So the first thing I said is, why lumpectomy? You know, right away. It's like, it's just gonna come back. It's like, just have it taken out. I said, what is a breast anyway? I mean, each person is different. Okay, what is a breast anyway? But of course, I'm not a doctor. She listens to her doctor, and the doctor says lumpectomy. And she went through lumpectomy. She's been in remission for, I'd say, 4 years now, 3 years now. And then I have a friend, classmate in pharmacy school, and she told me, and she's in France. So this one's UK and then France. She said, I had a big tumor, stage 3. She said, I can't remember stage 2 or stage 3, but it was big. She said, she works for the Ministry of Health. So all the best oncologists in France worked on her. And she said, lumpectomy as well. So that's when I figured, oh, so in Europe, they do lumpectomy. And both my sister and my friend are doing just fine. Okay. Hopefully it doesn't come back. The reason I was so opposed to it right away was just take it off, take the whole breast off, right? Because I don't want it to come back. I don't want it to come back or go to the other breast. Okay. Who knows the story of Angelina Jolie? Okay. Ms. Trisha, can you enlighten me on Angelina Jolie? I know a little bit, but I don't know the whole story of her chopping.
She has a family history. Her mother had breast cancer, and she actually is BRCA positive, which means she has genetic predisposition, and the percentage is extremely high. I believe like high 80s or 90s, that if you are positive on that gene, which is the BRCA gene, then you will get breast cancer and or ovarian cancer. So she decided to be proactive and to, because she knew that high percentage that she would get it. I think breast, I think, is like in the high 90s, and then the ovarian is the one that's more in the high 80s and 90s, but she chose when usually they do both. So she actually chose to have her breast removed, and I think she did the hysterectomy as well.
Both, right? Both?
Yeah, because she was at such a high risk for it that it was just like a matter of time. It wasn't a matter of if she would get it. It was a matter of time of when she would get it, and she just didn't want to not be there for her kids. So, and nowadays, because I had a pharmacist, she was my pharmacist that I worked clinically with every day, and she, her mother had breast cancer, and then when I worked with her, she got diagnosed with breast cancer. She was like 35, 36
That's
at
young.
the time. Yeah, when she was diagnosed, and she also was BRCA positive. So they did a mastectomy on both sides, but they reconstruct them now at the time of the mastectomy. So she got,
wow.
Yeah, that's the new norm. They put expanders in. So you get the expanders put in during your mastectomy. That way it can stretch the tissue that's, the skin pretty much. There's not much breast tissue, if any, because they take all of that out to your chest wall to make sure. Yeah. And so she had expanders put in, and then she had to go back for surgery just to put the implants in. But she went through 4 cycles of chemotherapy as well, which I guess you can choose to do that, but you're at lower risk for getting it in the chest wall if you do the chemotherapy. So she actually did chemotherapy for 4 cycles after her mastectomy, and then went back and got her hysterectomy then like a year or so after she was done with all of the chemotherapy and everything.
That's interesting. Okay. So you can't just go to a doctor and say, take my breasts off. I wish I could, right? Just take my breast off, because my mom, my sister, 3 of my cousins. So I wish I could just say that. So when Miss Trisha found out, she's like, did you do your BRCA test? No. Okay. I should go for my BRCA test.
Yeah,
but here's the thing. My friend in France, she said, I was negative on the BRCA.
Okay.
Okay, so it's not 100%. There's nobody in my family, she said, who's got breast cancer. So nobody, okay? And then she said in December, because I saw her in France when I was in France, she said, and she didn't tell me at that time that she was going through chemotherapy. She just showed up with her, but it was cold when we were there. She just had a scarf wrapped around her hair, and it was cold. So I thought it was, yeah. So when I got back here in the US, that's when she told me that the time I met up with you was I was going through chemotherapy, and she said, this is what happened. So anyway, she told me about the tumor, and then she said that they actually took out the areola nicely, okay, and then they put it back. She said, girl, I wanted to show you, but I won't because it's still burnt right now. So you know how like girl talks do like that. I said, why lumpectomy? And then that's when I put the two and two together. My sister had lumpectomy, and then lumpectomy both in European countries. So they preserve the breast. And she said, yeah, they preserve the breast because you're a woman and you don't want to go through that depression and all these things. And I think it's working for them. So each country has their own protocols or their own practice. Like what I said, you can't just go to a doctor and say, take it off, okay? The insurance will not cover it. Plus at that time, this is about 10 years ago, like, right, Ms. Trisha, with Angelina Jolie,
Yeah, I think it was around I can't remember if it was around the same time as my pharmacist was going through it. It hasn't been 10 years, but I'd have to see. I can't remember. I would say probably like 7 years ago.
yeah,
But
so
it's really cool though. They obviously took everything. So she got her areolas tattooed back on, and they look like so real. It's just amazing what they can do now.
right, yeah, they do a good job. I mean, because breast cancer has become more common, more and more and more common. Of course, if you have history, that's one. And then I think breast cancer is one of those cancer wherein when detected early, high chance of survival.
Yeah.
High chance of survival as long as it's detected early. Okay. So going back to my friend, she said she tested negative on the BRCA, no history in the family. And then December, she said she fell ill, like high fever, and she was rushed to the hospital. Okay. There was already pus. Okay. So it reached that point because she went negative, negative, negative. She got all this biopsy. It's a matter of months. I have another friend, another pharmacy school classmate. It was the same. I think it was negative in March and then positive in May. It was crazy. It's like, how did this happen in just 2 months? So you cannot tell. Chemotherapy, Ms. Trisha, let's talk about chemotherapy. You guys know that Ms. Trisha is a chemo tech. Okay, she's handled a lot of chemo drugs. Administering drugs to treat cancer affects primary tumor as well as migrating tumor cells. Primary chemotherapy versus adjuvant chemotherapy and palliative chemotherapy. Ms. Trisha, can you differentiate and can you tell us the cycle? Like, is it a 7 treatment, a 4 treatment? How do you decide how long is the treatment for each patient?
It depends. We followed through pediatrics. They went through the children's oncology group and they followed their protocols. So they have what they call a roadmap. So each person or at this child where I was at, once diagnosed with, say, leukemia, they follow the same protocol. And actually, I was very excited to find out that leukemia in children and pediatrics has an 85% cure rate now. And
That's
adults,
good.
yeah,
and remember, the most common cancer for children is leukemia.
Well, in adults, it's not that at all. It's only like 50s, I think, 55, maybe 65%, but it's really high in adults, in pediatrics. And so actually the kids, they go through a very strong regimen, very right off the bat. That's obviously when their immune system's going to be the lowest, and they go in and they just hit them with chemo really hard. And actually within the first 4 weeks of treatment, they should, after that, test negative for leukemia. Okay, so they'll technically be in remission, but that doesn't mean that their chemotherapy stops. They will then be on chemotherapy treatment for 2 more years. So for 2 years after that, they will go in and they will do maintenance chemo where they'll get it every so often. It's more often for this amount of time, and then it lessens and lessens as they get closer to the end of their treatment. Now, sometimes we've had patients in that maintenance that they would come out of remission and they'd have to start all over again in the beginning. So it is relapse is what they call that. So it is not that common, but it does happen that they would relapse. Then you have some that go through the whole 2 years and they'll do well, and they might go and they go for their checkup all the time, and they may find some cancer cells again, and then they'll have to go through the treatment. So it varies with each different type of chemo, how many, they call them cycles that they'll do. In pediatrics, like I said, they follow this roadmap, and so they go through a certain amount. You know, they'll get maybe 2 or 3 drugs together on this week, and then they'll only get 2 together on this week. So it's amazing that they've done that much studies and everything and found that this is how pairing those drugs together and doing those in that time at the exact right time in their therapy is actually what is the best success rate for them to go in remission. So it's really interesting. I haven't read about it in a while, but I used to read about it all the time when I was, in the field, in that job, just because I wanted to have as much knowledge as I could.
Yeah, chemotherapy alone is delicate to handle, and then all the more if it's pediatric chemotherapy, because it's even more delicate, right? Because we're dealing with low doses, okay? So accuracy is very important when it comes to dosage calculation. That's why when Ms. Trisha and I talk about math, we can't just be, guesstimate or estimate. We can't. So you're going to think that, oh my gosh, Ms. Trisha's so strict or Ms. L's so strict when it comes to this. We always try to think that we're dealing with babies. We're dealing with peds, okay? So we want the math to be accurate. Okay, so each treatment is different when it comes to chemotherapy, okay? Right. But we do have primary, adjuvant, and palliative. Ms. Trisha, do you want to explain the differences between the 3?
Well, I think the primary chemo is that initial chemo treatment that I was talking about, and then adjunctive is that maintenance that I was talking about. But unfortunately, palliative care means that, because there's a lot of cancers that aren't curable, they're only treatable, which means they will get treatments for them to prolong their life. So that is what palliative chemotherapy is. So they may use it to shrink a tumor because it may be pressing, depending on where, say it's in the lungs, it may be collapsing that lung or causing pressure on the heart, because the lungs are right next to the heart. Depending on where it's at, a bone cancer, my dad's lung cancer spread to his bone, and he was in such agonizing pain that they did radiation on the bone to try to get rid of the spots that he had in order to try to get him out of some of the pain that he was in. So, they have treatments, and but unfortunately that was just palliative. That was just trying to keep him comfortable. They always, I think everybody's goal is always cure. Although some of them are not curable, I think everyone wants to fight for that cure. There's just unfortunately some cancers, lung cancer being one of those, that are not found until late stage, usually because that was my biggest question to the oncologist when my dad was diagnosed. I'm like, I just don't understand. We didn't have the warning signs, not the warning signs that would make you think that he had back pain. I mean, he wasn't coughing up blood. He wasn't short of breath. I mean, he was in his 60s, so he would get short of breath, like when doing work normal, out of the norm for him, but not just like walking from one room to the other. And she told me, she's like, unfortunately, lung cancer is one of those that it's usually not found until it's already stage 4. That was with my brother-in-law as well. That's what my brother-in-law has. I'm going to see him. He is in stage 4.
I heard that bone cancer is the most painful cancer.
Yes.
because it's
That's what I hear too.
it's your whole body. Your whole body has bones, so it's the most painful breast cancer. It's the most painful cancer. And then chemotherapy, going back, primary chemotherapy, that's the initial, as the term implies, primary. Adjuvant is a treatment of residual cancer. Say, for example, after surgery, there's something left. Okay, there's something left, and that's the adjuvant chemotherapy. When you say palliative, the main goal is what? Not cure anymore, but comfort. Okay, to improve, like you see here, to improve the quality of life.
Yeah, and the difference between adjunctive chemotherapy and neoadjuvant,
Adjuvant.
yeah, is that the neoadjuvant is actually usually when they use radiation to shrink it so that they can go in and remove it. And the adjuvant is after they've removed it, they go and then treat the area around it to kill any cells that may have been left behind, because maybe they couldn't get it all. Maybe it was too big, or it was too close to a major organ or something, and they just couldn't get enough that they felt confident that they call them margins. So they couldn't get all the margins that they needed to for that.
Okay, thank you, Ms. Trisha. So there are different factors why a patient with tumor will go through chemotherapy. Depends on the size of the tumor. Okay, those are factors. The cell resistance to chemotherapy, the amount of chemotherapy given, condition of patient prior to chemotherapy. Okay, condition, age, health status, that's part of the condition. Okay, say for example, I'm a 90-year-old woman. Okay, they suggested chemotherapy to me, and say for example, Blanca, you're the primary caregiver, and you're the one who has power to make a decision. I'm your grandma, okay? But your grandma, your grandma, gave you the power to make a decision towards the end of life. How do you call that, Ms. Trisha? I forgot. Advanced directive. Oh
Advanced
my God.
directive. Good job. You just had to say my name. Yeah.
Okay, so it's tough because every time I go to my primary care, that's one of the first things they ask me. Do you have an advanced directive? Do you have an advanced directive? Do you have an advanced directive? Those are instructions to doctors, healthcare providers, when something happens to you, who makes the decision, okay? And they always recommend that, especially for multicultural. They always say that because usually Asian families interfere, like the parents interfere with the decision making. The mom wanted to make the decision for her and then takes away the husband in the equation, all this stuff, okay? My primary care doctor is Chinese, so she talks about that a lot. So anyway, if you have the if you're the one put on the advanced directive, you have the power to make a decision for grandma, me, 90-year-old, but I'm so frail. Okay, I'm not an active grandma who goes to the gym, does Zumba with my friends. No, I'm not that 90-year-old grandma. What if a 90-year-old grandma who's so frail and was suggested chemotherapy? And now you have to make a decision to go or not to go for chemotherapy. Grandma is not there 100% anymore, so you have to make the decision. Grandma can say, I don't want chemotherapy, or I want chemotherapy. What are you going to do, Blanca?
I think I would I think I would have her go through chemotherapy. I think I would take that decision.
Why? I'm not saying it's right. I'm not saying it's wrong. I
Yeah.
always throw questions like this, okay? I always throw questions like this, like, okay, you have a lot of money, but there's no cure for the drug, or there's a cure for the drug, but I always throw situational stuff like this. And I want to hear what your reasoning is. Okay, grandma, you will go through chemotherapy. Why?
Well, I guess 90-year-old woman is kind of controversial, but I guess it would be something that I would have to talk to her first about, I can't just go.
It's not 100%,
I would want to.
huh? So
If
she's
she's not
got probably dementia. Sometimes she's there, sometimes she's not.
If she has dementia, and she's 90, I think I would. I think I would just not put her through
Stop
chemotherapy
clicking. I
then.
can't hear you.
Oh, huh?
Are you
Can you hear
clicking
me?
pen?
No, I'm not cooking. Cooking?
Clicking pen.
Oh yeah, I can. Yeah. Yeah, I think I think I'm gonna go back with my answer and not put her through chemotherapy because she's 90. She has dementia. If she was 60, I would put her through chemotherapy. But again, it's very controversial. I'd have to be in that position, and I haven't been in that position ever in my life, so I don't really know how to answer that question.
Very good. It seems like your grandma's favorite grandchild, because for her to give you the advance directive, the power, you are the favorite grandchild. So the emotions play in here. Okay, what about you, Nyla? You're in that situation. I'm no Zumba grandma. I'm very fragile, grandma, and sometimes I'm 100%. I'm telling you stories about, during my time, I was teaching, and then all of a sudden the pandemic happened, and then there are times I'm like, who are you? And then the doctor tells you, you have an option to have her go through chemotherapy or not. It's up to you.
I wouldn't do it because my grandmother now she tells me that she doesn't, if something major happens to her, she's so old, she's like, don't put me through that, don't make me suffer. So I know that I just wouldn't do it. I wouldn't make her suffer because some people suffer when you try to expand their life longer than it was supposed to be. They do, and I just wouldn't do it. Not my grandma.
Yeah.
No.
Yeah, sometimes when I throw in situational, it really hits home, okay? Because you're in that situation, okay? Let me tell you this. My mom was 56 when she passed away. She suffered from breast cancer for 3 years, went through chemotherapy, couldn't handle it anymore, and gave up on chemotherapy. When she was, the day she passed away, I heard her clearing her throat, and my bedroom's next to hers. So I ran first, but she passed away. I was holding her hand when she passed away. Her request was, do not take her to the hospital. Do not take her to the hospital when worse things happen. Okay? She said, I don't want to be intubated. I don't want to be in a machine. So at 56, we followed her orders. She died on her bed. That's what she wanted. And she did, holding me and my other sister. And then my dad was there too. And then we started calling our other sisters who just live within walking distance. That's how she did it with us. So, and every child, every daughter, it's 9 of us, all girls, has a house close to where mama lives. So she can see everybody. But when my mom passed away, everybody started moving a little farther away. So she was that glue. Anyway, so she had specific orders to not take her to the hospital. And she just wants to die on her bed. And we did that. It was so difficult, of course, for the family. When I first started talking about this, when I was teaching earlier on, I just cry and I lose it. Okay. And that's why they said the more you talk about it, it's part of the healing. And the more, it's not like it's normal. It's not like I don't feel anything, but because when it gets to this part, I talk about cancer, I talk about her. Okay. The first time, of course, was very difficult. I couldn't even get back to the lecture. Anyway, what about you, Eileen? Your case.
If it was me, I would say I won't put her through chemo. Just depending on how she looks and how she feels. But even with her age, I probably won't put her into chemo because I know that they're already old, their bones are brittle. So putting her to chemo will probably put her in more pain. So I'll just, let her die when the time comes.
Yeah. And especially if they request when they're still 100%. We gotta respect those requests. Okay. What about you, Joey? What if I'm your grandma and I still do Zumba with my friends every morning at 7 in the morning? And I'm there because it's each person's different, right?
Mhm.
Yeah. And then they said chemotherapy. But then I tell you, nah, I'm not gonna let you.
Okay, so you're telling me Lola is active.
Lola is active. She's got all these amigas. Okay. She goes Zumba with every 7 in the morning. But she tells you, you will not let me go through chemotherapy. I'm okay.
She's a 90-year-old woman, and by this time, I would assume that I am an older man, and I'm gonna be like, Grandma, that's honestly gonna be up to you. I would offer, like, do you want to try like any alternative medicine just to make your time easier? And I'm talking about THC. I'm talking about marijuana. I'll ask her, I'll be like, yo, you wanna try this? Like, this will make your time a lot better. Like, you'll just, like,
And of
grandma, like,
course, you're gonna join, make sure you're not letting her do it alone, right?
oh, most definitely, yeah.
Yeah.
Okay, and this is so funny.
But,
Okay.
and I say that because I just watched like a handful now. I feel like, your search on your computer is all dependent on, or like what pops up on your feed is all depend on, my grandma just gave me this ring too. It's all dependent on what you look up, right? And I watch a lot of like podcasts with Joe Rogan, and we all know, if you guys don't know who Joe Rogan is, he's a big weed pothead.
Here's the cause why Tesla's stock went down.
Hey, Elon Musk do what he wants, right? He should be the president. But anyway,
Okay, go back.
yeah,
This is a good topic, which I'm gonna tell you something about me being an ironic pharmacist. Go ahead, Joey.
and I went into a little YouTube wormhole, and I watched a couple documentaries, and there's a whole community of people that that either do chemotherapy and like they aid it with like smoking or eating edible THC, and they get cured and they feel really good. And there's some people, like, there's a couple rare cases where, and I think it's probably just the power of the mind, where they completely get off of chemotherapy and they just smoke that good kush and they get better. And I think that's all in here, honestly. But again, there's a lot of people that I've read, and I've watched documentaries with people that have pretty bad cancer, and they take chemotherapy and they aid it with THC and they feel better. So I will say, Lola, keep doing your Zumba and smoke this tree of knowledge. That's what I'll tell you.
Okay, so this is funny. I talked to this with my friends. I was only 15 when my mom passed away, so I wasn't a pharmacist yet. I never knew I'd be a pharmacist, but the first time I handled drugs was because of her. Okay, so tamoxifen and and all these drugs that she's taking, I have to pop it out and then hand it to her. So I never knew that I'd be a pharmacist. It's not like a dream that I want to be a pharmacist. She just knew I'm going to be a doctor because I said that. But then I realized I don't like blood. So had I known, I tell this to my students, had I known what I know now, okay, my mom's so opposed to any type of drug, okay, especially illegal, especially marijuana, okay. I think I'd be that daughter who'd bring her the happy brownies.
Mhm.
Okay, I think I'd be that daughter had I known what I know now. Okay, because I saw her suffer in pain for 3 years and it was heartbreaking. Okay, what the oncologist told us was, for the patient, it's only physical pain, but for the family, it's physical, emotional, psychological, and financial. Okay. So the family suffers more, Okay, because the primary concern of the patient is the physical pain. So yeah, had I known what I know now, I would have been that prodigal daughter. I couldn't bring her a joint. My sisters would kill me right away, and she'd kill me too. She wouldn't even take it. I'd probably have brownies ready for her, or maybe gummy bears, whatever, just so I could trick her into taking that. Why? Again, let me show you this part. Improve quality of life. Okay. However, marijuana, let me take this chance to tell you guys, marijuana is illegal, okay, federally. It may be legal in many states. There are 11 states where marijuana was legal originally, and Nevada is one of them. Hawaii, Nevada, Washington, okay? So this Maryland, okay? And then there was an election and people went out to vote, not really for the president, but they went out to vote to make marijuana legal, okay? Just so you know, marijuana in the medical field, no. Okay, so you still are going to be drug tested before you go out on externship, and random drug testing happens too at school. Okay, you can be called to go for a random drug test next door. Okay, so the medical field and marijuana doesn't go together. Okay, in my 10 years, 12 years total teaching, we've had a good number of students, I have stories, a lot of stories, who got terminated automatically for testing positive on marijuana. Okay, I'll talk about that later, but I want to talk about THC, the derivative, Miss Trisha, right? We actually use a drug in the hospital, okay? That is a derivative of THC. And what is that, Miss Trisha?
A derivative of THC?
Or THC itself. I can't say because it's got a lot of L's and R's.
Yeah, well then, if you can't say it, then I'm not going to be able to say it.
Okay, Dranobinol.
Dranobinol.
Okay, what is Dranobinol? It is used to treat nausea and vomiting caused by cancer chemotherapy. Okay, what is it? Dranobinol, also called THC.
I know we used to use cocaine surgically.
Yeah,
Mhm.
still,
I think
okay.
Sometimes they still do, don't they? Do they do it?
Still do.
Yeah.
Okay, so these are drugs that you'll find in a hospital. Cocaine is a C2. It's an anesthetic found in hospitals. But when it's crack cocaine, it's a C1. It's illegal. You get it? You have to know that, okay? You know the difference. Why? Because it didn't go through the quality control process, and they may be what? With what? Detergent, mixed with detergent and stuff, okay? But Dranobinol, okay, is actually THC, a man-made form of the natural substance in marijuana, cannabis, okay? And we use it for cancer patients to treat nausea and vomiting, okay? It is a C3 if I'm not mistaken. Is it a C3 or C2? Can somebody look it up for me, Dranobinol?
Yeah,
They
if it's
always
from- if
change.
it's from
That's why.
nausea, I bet it's a C at 3. I can't imagine it being a C2.
Dranobinol is a, and then we also have Marinol,
Yeah.
which is the brand name. C3. Okay. I always check because sometimes it changes. Okay. I mentioned the chemotherapy drug in the lecture packet. And what is that? Letter T. Used to treat ovarian cancer. On the first page of your packet, Eileen. Taxol, very good. Paclitaxel is the generic. The generic is paclitaxel. The brand name is Taxol. Okay. I talked about cytotoxic materials. I told you cyto means cell. Toxic means toxic. Okay. Poisonous. So ones that are poisonous to cell, and our chemotherapy drugs are cytotoxic, considered cytotoxic materials. I have to correct something in your packet. Antibiotic is used to treat cancer and produce severe emesis. Yes or no, Ms. Trisha?
No,
No, it is not used to treat cancer. Okay, chemotherapy is used to treat cancer and may produce severe emesis. What's emesis?
vomiting.
Vomiting, throwing up. Okay, so chemotherapy side effects. What are side effects of chemotherapy? Nausea and vomiting. What else? What happens to the hair? Falling hair, right? Okay, so you'll see a lot of patients going through chemotherapy who are bald. Okay, who are bald. I remember my sisters got my mom a lot of wigs, and she used to wear it. Anyway, so it's chemotherapy. You want to correct your packet. Okay, and what do we give patients who are on chemotherapy who's got severe emesis? Brand name letter Z, generic letter O.
Zofran.
Zofran is the
Ondansetron.
brand name. Sorry. Zofran is the brand name. The generic is Ondansetron. Say Ondansetron. Unmute. Everyone say Ondansetron.
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 Say Zofran.
Zofran.
You know what I remember when I say Zofran? Zoolander. I don't know why.
That's funny.
I don't know why. You'll probably remember it because I said it. Anyway, so Zofran is not only given to chemotherapy patients. Hang on, I'm going to lose my train of thought.
Bruh.
Zofran is not only given to chemotherapy patients. Zofran is, oh no, I was thinking Zohan, not Zoolander. Is it Zohan? Another Ben Stiller movie.
What
Nyla, can you unmute yourself? Zohan.
It's Zohan.
Zohan, that's why. Okay, not Zoolander. See, I get it mixed up, but it's both Ben Stiller, right? Okay, so that's what I remember. So going back, Zofran is the brand name. The generic is Ondansetron. Okay, it is used for emesis, severe emesis. We do not only give this to chemotherapy patients. However, we also give this to those who are not going through chemo but has severe emesis. Okay, I remember when I took my son to urgent care. I can't remember if it's urgent care or ER. When he was still so young, they gave him a pediatric dose of Ondansetron. Okay, it's in syrup form. Okay, and this can be made from it's part of those things that you can actually do in compounding. Okay, when the pediatric form is not available, you can make a tablet or a capsule into a liquid form. Okay, so he was given the syrup. Why? Because he was throwing up. And what happens when you throw up a lot? You're gonna be
Dehydrated.
dehydrated. Okay, and then one last thing before we go on break: Neupogen, filgrastim, given to chemotherapy patients who have low white blood cell count. Okay, let's review. What's the difference between white blood cell and red blood cell? Nyla.
What do you mean? What's the difference?
Don't tell me one is white, one is red. In function, why? What does it do? What does the white blood cell do versus the red blood cell? Tell Mr. Jackson you didn't learn anything from him.
No, don't do that. I learned a lot from him. Don't do that.
I'm gonna tell Mr. Jackson. Okay, call a friend.
Eileen.
I'm gonna tell on you guys.
Okay, the white blood is for immunity and red blood carries oxygen.
Very good.
That's what I learned.
Okay, very good. So usually white blood cells is for your immunity. So when you have infection, which one's high? Is it the red blood cell or the white blood cell?
Right.
The white. That's one of the signs, okay, that you have an infection when they do a test, okay? Any questions? I want to end the oncology so we could do our EENT, okay? And we also have integumentary, which is dermatology, okay? Any questions on this one? Ms. Risha, you want to add something on chemotherapy since you are my go-to and the expert on especially pediatric chemotherapy?
Well, if you ever make Taxol or paclitaxel by IV, always remember you cannot use the regular tubing, which is the DEHP tubing. You have to use the PVC, the polyethylene line tubing, because it will react. So the paclitaxel will react with the tubing, and then that will go into the patient. So no bueno. So you just got to make sure, always remember, if you get that drug, make sure you use the different tubing. Don't use the DEHP. You need to use the PVC lined tubing.
Yeah, that's a very, very good point. I'm glad you mentioned that, okay? What she meant by it will react, the chemicals of the tubing will react to the drug itself and form a different chemical that may be toxic or that may kill a patient or it may damage a patient. That terminology is called leaching, Leaching, leaching. When the container, say for example, normal, actual practice, you always hear, do not leave water bottles, right, in the car, especially during summertime. Yeah, because the chemicals from the plastic container will actually react to that water, causing what? Creating a different chemical that may be carcinogenic. Okay, and that term is called leaching, Leaching. Okay, any questions? No, it's 11:05. Let's come back at 11:10 with your worksheets. What are the worksheets, Ms. Trisha, that they should be ready with?
Oh, geez. I was still on pharmacology.
Sorry.
Grains,
Okay, can somebody say, Nyla, what worksheets should be ready when we come back?
grains to milligrams, metric to household, and value.
Correct. I cannot promise that I'll be able to do all of them. We'll be able to do all of them, but we will get through whatever we can get through in 1 hour, okay? Get them ready. And there is a submission link, Ms. Trisha, right?
Yes, and I gave you guys that link and told you they needed to be uploaded before class today.
Yeah, okay.
Yep.
Joey, after class, I want you to stay because of what you emailed me, okay? So see you guys at 11:10. Bye.